Hello, this is Cameron Sabat from Cutting to the Case, Conversations in Orthopedics, and I'm here today with Dr. Adam Starr. Adam Starr is a globally recognized orthopedic trauma surgeon and the Hansjörg Wyss Distinguished Professor at UT Southwestern. He pioneered percutaneous pelvic fracture fixation and co-invented the Starr Frame. As medical director at Parkland Hospital, he leads innovation in fracture care and has authored influential textbooks, chapters, and peer-reviewed studies. Thank you very much for joining us today.
Yeah, thanks for having me.
Yes, absolutely. So I have a series of questions over these next 15 minutes, and just to get to learn more about your career and your approach to innovation, and you've had a very storied career here. So you've helped revolutionize pelvic fracture care with percutaneous techniques. Can you walk us through the clinical moment that first made you realize open approaches were failing patients?
Well, the truth of the matter is that the guy that trained me, a surgeon named Charlie Reinert, was already well down the pathway of percutaneous surgery around pelvic fractures by the time I encountered him. So Charlie showed up at Parkland when I was a medical student, and it was clear that he was doing things uh, that were beneficial. If you can fix a pelvic fracture with teeny little stab wounds, then that's got to be better for the patient. So he kind of rolled me up into what he was doing, and I stuck with him. I did my fellowship at Parkland with Charlie, and then joined the faculty there at UT Southwestern and worked with Charlie for years and years, and that behavior of him persisted. I mean, he was an innovative guy and was really good with his hands, great surgeon, and smart. And so I was lucky. I just happened to fall into a situation where I had a guy who was really a genius, and I just sort of tagged along and watched what he did. And it really, it was been a lot of fun.
Mhm. Certainly, certainly. Working with, leaders in the field, and UT Southwestern's no slouch there. I mean, it's a hotbed of innovation. So, yeah, that's fantastic. And really, the Star Frame has had international impact. What were the earliest challenges in designing and testing it, and how did you know it was ready for widespread use?
Well, the frame is kind of funny. So the frame was developed mostly out of laziness, right? So uh, when you're just if you I don't know if you've treated any or not, but if you're treating let's say a vertical shear, pelvic ring disruption, usually there's somebody who has to pull really really hard on the leg to reduce the vertical shear, and that somebody was usually me. So I was usually the guy who was pulling on the leg, and it's tiring. And
Mhm.
so I figured there's got to be a way that we can sort of anchor the uninjured side to the table so that we have something to pull against. In the old days, somebody like the med student or the resident, junior resident, would hold the uninjured side to the table while the other guy pulled. And really, the frame just does that. I mean, it just anchors one side of the pelvis, and then you manipulate the other side with perc instrumentation, and it was just a way to avoid work. So
Yeah.
that's how it came about.
Yeah, yeah. No, that's fascinating. I mean, it's amazing how much can come out of the need to, reduce the hands on a patient in a
Yeah.
surgery. Yeah, yeah. So, minimally invasive pelvic surgery allows these patients to mobilize faster and avoid common complications like wound dehiscence, which is revealed in the literature. How do you decide which patients are appropriate candidates for these percutaneous fixations?
Well, in my hands now, if there are acute fractures, virtually everybody's getting treated percutaneously. I don't do any more open reductions because usually, I mean, the vast majority of the time, you can get the thing reduced percutaneously. And so the question then, the real question is, how do you assess your reduction? How do you know that it's good enough? And I'm lucky. The place where I work, Parkland, the X-ray technicians are superb. I mean, they're really really good. They're excellent at their job, and they can show you what you need to see really really rapidly. They're very experienced. And so I think the next horizon, the next challenge for us, the guys, the kind of people who do this sort of work, the challenge is going to be, how do we make sure that the thing is as good as we think it is, the reduction is as good as we think it is, and then how do you prove it? How do you prove it? And we've been using fluoro for decades now, and I think everybody's very comfortable with fluoro. I think that probably the next step is going to be use of three-dimensional imaging, like there's a lot of devices now that give you essentially a CT-like image. And so I think that the use of stuff like that, technology like that, that's probably the next step. I don't think that most of us are routinely doing that. I think most people still rely on fluoro. There are a number of centers. The guys in Zurich, for example, are using that technology to navigate their screw placement, but that's not that common. They're really innovators there. But I think that's the next step. I think if you want to make sure that you've got it as perfect as you think it can be, that's going to be the next step.
Absolutely, yeah. And then that actually, the whole idea that the X-ray techs are great, but we need these 3D CTs. That kind of went right into my other question as well, which was how has you've really been at Parkland for over 2 decades, so you're a unique voice there. How has trauma care evolved there? What are the most exciting things? I mean, beyond even this fluoro.
Well,
And 3D CT.
I think the trauma care is a lot better. I mean, we save a lot more people. I think the general surgery doctors that I work with are experts. They're superb. We're lucky. And Parkland is one of those hospitals where trauma is sort of in the DNA of the hospital. They really care about it. And so the hospital system, by and large, is very supportive. So if you come up with you say, hey man, I need this or I need that, generally they'll do it for you, which is not, that's not across the board. Other hospitals are not so generous. So I'm lucky there. So really the care has gotten better across the board, not just in orthopedics, but in all the specialties. The ICU doctors are excellent. They save a lot more people. I think that one of the things we've been working on at Parkland is the use of algorithms. We have an app called the PTIM, Parkland Trauma Index of Mortality, and we're trying to use that to help us decide when is it safe to go to the OR for fracture fixation. And if you pay attention to the literature, study after study after study bangs the drum that early fixation is better. The patients do better if you fix them earlier. And then the question becomes, well, in a polytrauma patient, when is that safe to do? When are you safe to take somebody to the OR? And the truth is that most of the time we just sort of eyeball it. We walk around and we say, oh, I'm going to look at the lactate, look at the base deficit, whatever. And then if you pin somebody down and you say, well, okay, well, what lactate is no good? They really can't answer you with any sort of authority. So we've been working on that. I think that things like that will probably come more to the fore in the next few years. People in your generation, I think that that's going to be something you just sort of take for granted. I think that the way my iPhone is sort of a daily miracle to me. I don't understand how it works, and it's sort of miraculous that it can do all these things that it does. And I think that surgeons in your generation will look at these AI assistants in much the same way. You're just gonna say that's sort of a given. So I think that we're almost there. I think it's just a matter of time.
Absolutely, yeah. And then having come from, I'm at Georgetown right now, but I've been in GW ortho trauma. I've seen how looks can be deceiving in polytrauma cases, like when there's a little cut in the head, and the head's a very vascular place, and it looks much worse than it is, or vice versa. The patient looks fine, but there's something terrible going on.
Yeah.
So
Yeah.
it's really incredible to see moving from that subjective assessment to this objective guidelines. Um, so. So also, just last two questions. pelvic and acetabular fractures, they're really rare, but often devastating. What advice would you give to young surgeons who want to build expertise in a high complexity, kind of lower volume niche?
I think the key is reps, repetition. So you've got to, if you really want to do this kind of stuff, then you need to go somewhere where they get that kind of stuff. You can't go you can't go to a community hospital and expect to do those kind of cases, because if you see them at all, they're going to be very, very rare. So I think that, frankly, I think that the way the Brits have their system set up, the NHS system, their trauma system, I think that's what we need in the U.S., but I have no idea if we're ever going to get it. But I think that you need concentration of cases to develop concentration of expertise.
Mhm.
And so I would say, if you're a young American surgeon, go to a place where they do a bunch of these cases and kind of attach yourself to somebody that's doing that work. One of the benefits of the surgical training regimens is that they sort of foster mentorship. You kind of have to have it.
Mhm.
And so if you can find somebody who's interested and has a career in that, attach yourself to that kind of person, and then you'll learn right away if you want to do it or not. You may say, gee, this really sucks, this is really hard, I don't want to do this. But I think that's really the pathway to learn how to do it.
Yes, yes. Um, and UT Southwestern being in Texas, really in Dallas, Texas, that is a prime location for a lot of trauma. I've seen Houston, Dallas. I was just at Ohio Health, fifth busiest trauma center in the U.S., or even Henry Ford. All of these amazing locations that aren't necessarily Ohio Health isn't Harvard, and yet you get so many more reps in
Yeah.
going there. So it's really incredible to see. It's a different approach than maybe in other fields. Um,
Yeah.
so looking ahead in 10 years, final question: where do you think the next big shift in orthopedic trauma will come from? Robotics, biologics, AI, or something else entirely?
I think we've already talked a little bit about AI. I think AI will definitely have a place. I think that robotics is too it's too firmly fixed into arthroplasty and coming up in spine to say that it's going to go away. I don't think it will. So I think robotics will have a place. I think the thing that we need to do better as a group, people who do what I do better as a group, is teach. And I think that if you look at surgeons, people, my kids are grown now; they're young adults. But if they want to learn how to do something, they don't read a book. I'm a big fan of books. I like books, but young people don't look at books. They may look at a book as it's almost like a nostalgia trip. They flip through and oh, isn't this quaint? But if they want to learn something, they'll watch a video or they get on YouTube. And so I think we need to do a better job educating kind of where they are. Where the students and the learners are. And so I'm trying to do more of that kind of teaching. We can put stuff on YouTube. We can put videos on YouTube. We can make the journal articles more image based. You can't put a lot of data in that. I mean, if you want to, if you want data that's still going to be written and you're forced to read. But as far as teaching somebody how to do something, it's very hard to do that in a book. You can kind of do it with images. So I think that's probably something that we need to do better. I'm not sure that that's it's hard to teach. It's hard to teach people how to do stuff, and we need better ways to do it. So I think the internet, YouTube, and even robotics may help with that.
Yeah, absolutely. And orthopedics being such a visually based specialty, you're
Yeah,
looking at the bones, you have to feel
right.
it, simulators, 3D, AI, all of that. Yeah. No, I really appreciate you meeting learners where they're at. It really shows that you care about this. And
Yeah,
yeah, I appreciate it. Thank you very much for joining
sure
Cutting to the
thing.
Case.
Yeah, thanks for having me.
Yes, thank you. And this is Cameron Sabat signing off.
All right, man. Take care.